Hello, everyone, and welcome to the Children's Cardiomyopathy Foundation's webinar on sudden cardiac arrest, education, and prevention for pediatric cardiomyopathy families. My name is Gina Petty. I'm the Executive Director of the Children's Cardiomyopathy Foundation. The Children's Cardiomyopathy Foundation, or CCF, is a nonprofit organization dedicated to finding causes and cures for pediatric cardiomyopathy through the support of research, education, awareness, and advocacy. Established in 2002, CCF has grown into a global community of families, physicians, and scientists focused on improving diagnosis, treatment, and quality of life for children with cardiomyopathy. October is Sudden Cardiac Arrest Awareness Month, and in addition to hosting this important webinar during this month, we are also sharing information about sudden cardiac arrest on our social media channels, as well as hosting a follow-up special heart-to-heart discussion chat later this month focused on sudden cardiac arrest prevention and awareness. We will be sharing more information on these later, but I would also encourage anyone who is not already connected with us to register as a member with CCF or to sign up to receive our email updates. Links will be posted in the chat box for you to do so. During today's webinar, questions are encouraged and welcome. Questions can be submitted via your question box on the control panel. We will reserve the last portion of the hour to take your questions. You're welcome to submit questions throughout the presentation as you think of them, and then we'll go over them at the conclusion of the talk. This webinar is being recorded and will be available on our CCF website and YouTube channel in the coming days. We are thrilled today to be joined by Dr. Robert Whitehill. Dr. Whitehill completed his medical doctorate at the University of North Carolina at Chapel Hill. He completed his residency and fellowships at Boston Children's Hospital. He received additional training in caring for patients with pacemakers and ICDs as part of advanced training in electrophysiology. Dr. Whitehill's primary clinical and scholarly focus is heart rhythm disorders with invasive electrophysiology studies and device implantation. He is the medical director of Project S.A.V.E, which is dedicated to sudden cardiac arrest prevention and education, as well as director of electrophysiology at Children's Healthcare of Atlanta. Dr. Whitehill, thank you so much for joining us today and welcome.
It is absolutely my pleasure. Thank you so much for having me, Gina. I just want to say thank you to everybody who's logged in, who's coming to join today. It is an absolute honor for me to be able to be here and to chat with all of you, to spend some time together. It's just a delight anytime that I can chat with families of our patients. And I expect that I'll be able to learn a lot from you in the question part of this hour. Would love to hear what concerns you and how we can help. So let's launch in. So the topic today is sudden cardiac arrest, education and prevention for pediatric cardiomyopathy families. And I have no financial disclosures, and this is a topic that I think is nerve-wracking for everybody to talk about, but it's certainly something that has been in the news, it seems like, all year. So these are the scenes from Monday Night Football. Earlier this year, you can see the Buffalo Bills here, and distraught teammates as their friend and colleague, Damar Hamlin, received resuscitation from the Bills athletic training staff. Certainly this sort of kicked it all off this year, where this topic really sort of jumped into the forefront. But we know that it's not just professional athletes, right? These types of events happen in our communities too. You don't have to look very hard to find news stories such as this one here in the state of Georgia, where a young man had a cardiac arrest during a football practice. And then even just recently again this summer with LeBron James and his son having a cardiac arrest. So this is something that we really want to try and spend time highlighting, building education and awareness, particularly in October, which is Sudden Cardiac Awareness Month. But it's something that's been in the news all year. And while the athletes seem to get a lot of the press, it's not just athletes that this affects, right? What if it's one of these kids on the playground? What if it's somebody else in our family or somebody else in our community, someone else in our children's school. How can we identify people at risk? How can we say, my child has cardiomyopathy. How do I know if their risk is high or low, or what do I do? And I really hope that we can help jump into that topic today. So I also want to try and instill some hope. I think this is an exciting time to be in medicine, particularly. I think that we're getting better and better every day. And as you see Damar Hamlin returning to the field here, I think that in the modern era, we really are trying to get better about protecting the quality of life of our patients. And so we really want our pediatric cardiomyopathy patients to be able to have just the best quality of life possible. We want to try and put safety nets around them, but if we can get them back to doing what they want to do, if we can minimize their risks, as was done for Damar, then we want to be able to do that. So let's launch into a few questions together. Some of this will be very basic, but I think it's important just to start at the beginning. What exactly is a sudden cardiac arrest? I think there's a lot of different misconceptions about what that actually is. How often does something like this happen in pediatric cardiomyopathy and in the general population at large? And how can we recognize what individuals might be at increased risk versus others? And then lastly, a topic that's sort of near and dear to my heart and to the work we do with Project S.A.V.E. is how can we prevent a sudden cardiac arrest from becoming sudden cardiac death, and what secondary prevention measures can we have in our community, in our families, to protect our children? So let's start at the top together. What is a sudden cardiac arrest? So these are some beautiful diagrams I took from CardioSmart, which I encourage anybody to go look up if you want just some great visuals of sort of how the heart works and how everything is put together. And you can see there on the left a representation of the heart's electrical system. Okay, so that little white structure at the top is called the sinus node, and that's what your heart's own pacemaker is. So that's what sets your heart rate low when you're asleep and ramps up your heart rate when you're exercising. And it sends a signal through the top chambers of the heart, called the atria, into this little yellow node called the AV node, which then sends it down into the electrical system, causing the big pumping muscular chambers, the ventricles, to squeeze blood to the lungs and to the body. And this, of course, is oversimplified, but is a nice representation of this sort of complex web of electrical tissue that you can't see on an echocardiogram, can't see on a cardiac MRI, but we know is there and directs really all the mechanical movement of the heart. So what's a sudden cardiac arrest? A cardiac arrest is really a primary electrical problem. So as you see in the diagram to the right, essentially what happens is a chaotic or very rapid sort of depolarization or electrical signals from the bottom pumping chambers of the heart, outside often of the normal conduction system, where the bottom chambers of the heart start pumping very, very fast based on the signal they're getting, or in a very chaotic manner if it's coming from multiple different parts of the ventricle. Oftentimes pumping so quickly that the heart muscle is almost just quivering and can't effectively pump blood. That's a rhythm we call ventricular fibrillation. And that is something that can lead to a cardiac arrest when the heart is just not able to pump blood effectively. This, I think, is a really nice diagram showing the difference, because I often get asked, is a cardiac arrest and a heart attack the same thing? And I think there's a very important distinction to be made here. Whereas a cardiac arrest is a primary electrical problem, as I mentioned, sort of this chaotic electrical activation throughout the heart muscle. A heart attack is more of a plumbing problem, where the heart muscle itself is not getting enough oxygenated blood, usually due to some obstruction in the blood supply in the coronary arteries. Now, a heart attack can lead to a sudden cardiac arrest, for sure, but a sudden cardiac arrest is primary electrical. And I want everybody to remember that. At the bottom there, we'll get into this a little bit more, and just to make sure that everybody's sort of aware of this resource at cardiosmart.org, looking at how we can respond to these terrifying events appropriately. So how often does something like this happen? How often do patients with cardiomyopathy have these sort of electrical storms and these cardiac arrests? And Like everything, right? It's not one size fits all. Even within certain cardiomyopathies, the risks are different, of course. Even among the different cardiomyopathies, the risks are very different. And I want to spend the next few minutes sort of going through each of the major types of cardiomyopathy that we see and assess, just to show you that it really is a little bit different. And each unique form of cardiomyopathy has its own sort of risk profile and the important things which I want you all to be talking with your cardiologist about. Okay, so first up is hypertrophic cardiomyopathy. This is certainly one of the more common cardiomyopathies that we treat in our practice. And if you have a normal heart on the left, a basic diagram on the right there, I think you can see that on the left side of the heart, the muscle is incredibly thick, very thick in the middle of the heart as well. And when that happens, the heart continues to thicken, thicken, thicken. I think you can see there it's actually obstructing the blood flow out of the heart, out to the body. Along with the thickening of the heart muscle, you also start to build up scar. The heart muscle itself becomes very disorganized. And we know that in severe cases, hypertrophic cardiomyopathy is certainly a risk factor for cardiac arrest. But how often? I'll tell you, there is some exciting work that's being done by a couple large multi-center and international groups to try and better risk stratify our patients with hypertrophic cardiomyopathy and really trying to find who might need medicine, who might need a surgery, or who might need some other sort of change in the treatment plan based on their updated risk profile. And while a lot of that exists for adults, it hasn't always existed for kids until now. And so this is just one of the studies that's come out. I'll show you another in just a second. This is out of the primacy group in Toronto, sick kids, and they sort of defined that maybe 2 to 3% as a risk for sudden cardiac arrest in HCM patients after 1 year. They thought maybe 5 years, it's around 8 to 9%, and 10 years around 15%. And what they noted in this study by our colleagues, led by our colleagues in the UK, is that a lot of that risk is in this certain high risk group here, which you can see by the blue line there, showing that people with a greater than 6% sudden cardiac arrest risk in the next 5 years really carry a lot of that risk in that one high risk group. So what can we do about that? Well, we'll certainly get into that later. But importantly, both of these risk profiles came up with some predictors of what goes along with sudden cardiac arrest and hypertrophic cardiomyopathy. And here is a sort of seemingly long list, but these are all things that your doctor is already looking for, okay? First and foremost is something called non-sustained ventricular tachycardia. So I mentioned that ventricular tachycardia is an arrhythmia where the bottom pumping chambers, somewhere outside the normal electrical system, there's a signal that is causing those chambers to beat really, really quickly and oftentimes a little disorganized. Some people have that in a sustained manner, meaning it lasts a long time. Some people may just have it for 5, 10, 15 beats. And that's something that you'll hear your cardiologists call non-sustained ventricular tachycardia. And that's really important because in hypertrophic cardiomyopathy, it can actually predict that, hey, there might be something that could happen down the road if you're already starting to get these little shorter episodes. Passing out is a really big one. And hypertrophic cardiomyopathy, that's certainly something that we worry about. It's something we spend a lot of time talking with patients about in our hypertrophic cardiomyopathy clinic, asking, hey, have you ever passed out? Did you feel like you were going to pass out? Tell me more about that episode. That certainly gets us more concerned. Genetic testing results are important. In 2023, we're very fortunate that genetic testing is getting better and better and better. And you'll see that as I go through the other cardiomyopathies, that is also incredibly important. Later this year, I encourage you guys to log in when the CCF is going to do another webinar specific to genetic testing and how important that is. And this is just one other reason for that, because depending on the certain genetic result that we get with genetic testing for why a child may have cardiomyopathy, that can help us actually form a better prognosis and form a better risk stratification for how things are going to proceed. And then these last three things are things that you're going to get on just a baseline echocardiogram or ultrasound of the heart. Things like how thick is the heart, how big is the left atrium, and what's the gradient across the left ventricular outflow tract as that muscle gets really thick and it starts to block the blood exiting the heart. So these are all really important things. We know that they're predictors. We know that sudden cardiac arrest does go along with hypertrophic cardiomyopathy, but it is relatively rare, thankfully. Okay, so let's move into dilated cardiomyopathy. This also is a common cardiomyopathy that we treat. Okay, you've got your normal heart there on the left and a more dilated cardiomyopathy heart on the right, where you can see that the walls of the ventricle are now starting to thin out as the muscle weakens. And the ventricle, because it's not able to eject all the blood that it's getting from the top of the heart, it starts to dilate over time. And we know that that is a risk for sudden cardiac arrest as well, although the risk is much less than in hypertrophic cardiomyopathy. So this is based on a large registry that was put out or that was collected, and this paper came out a little bit, maybe about 10 years ago, but the numbers are still pretty good, where you can see that at 5 years, the risk of a sudden cardiac arrest for one of these patients in pediatrics is still pretty low, around 2%. And this paper highlights that while sudden cardiac arrest is a concern, the bigger concern is just trying to do whatever we can to support and maintain the function of the left ventricle as that muscle might be thinning out. So what are the risk factors here? What sort of things do we need to be paying attention to as cardiologists? Do we want our families attuned to help people decide what sort of risk category they might be in? And the top two, which I've bolded, very important. So any of these arrhythmias that we might pick up, and again, that may be something like the non-sustained ventricular tachycardia I went through already. And then anytime you have a left ventricular ejection fraction less than 35%, despite being on medical therapy, now we know that that increases the risk as well. So the left ventricular ejection fraction is a number that is calculated every time you get an echocardiogram or a cardiac MRI. And it's a simple calculation where we try to estimate the percentage of blood that is ejected from the left ventricle every time it fills up and squeezes. And while a normal number is 55% or more, once that starts to fall below 35%, despite being on good medication, we do start to worry a little bit that risk is going up. And then there's some other things that have been looked at, things like diagnosis of dilated cardiomyopathy at a very young age, which may signify that it's a little more of an aggressive course. And then LV wall thinning, as the wall really starts to thin and the function declines. Those two tend to go hand in hand. So these are all things that your cardiologist is looking for. But certainly, I'm thankful that you're here to educate yourself on these as well. Arrhythmogenic cardiomyopathy, another very important diagnosis that we treat. Okay, if you see your normal heart there on the left, in arrhythmogenic cardiomyopathy, it's not that the heart muscles necessarily are diseased in any way, but the connective tissue between them, the scaffolding that holds all the heart muscle together, is abnormal. Okay, and over time, that means that the muscles will have trouble really connecting and really coordinating their contraction, and that leads to the heart starting to dilate a little bit. And then that scaffolding breaks down. It starts to get replaced by scar and by fat even. And we know that increases your risk of sudden cardiac arrest and abnormal heart rhythms, as you see in the name. And this was a study looking specifically in children at arrhythmogenic cardiomyopathy and trying to figure out what exactly increases our risk of a cardiac arrest. And I sort of included this because this is a nice example in the top here in the A diagram of something that I've already referenced called ventricular tachycardia, where each heartbeat sends off an electrical signal that's very wide and very rapid. In the B diagram there, you can see at the very end, as the heart rate's going along very nicely, that all of a sudden it becomes very chaotic, very, very rapid. That's that rhythm I mentioned called ventricular fibrillation. And if you look in the D diagram over there to the right, you can see why our patients are at risk for both of these. If you have that nice dark muscle in between the two ventricles, you can see that part of that sort of circle representing the left ventricle there is replaced by this sort of bright white tissue. And that's all that sort of the scar and fatty replacement, which sets people up for abnormal rhythms. So what about arrhythmogenic cardiomyopathy? So any ventricular arrhythmia like ventricular tachycardia, as you see here, as the heart starts to get very dilated and the function goes down, similar to dilated cardiomyopathy, that increases your risk, okay? And then certain genetic testing results, just as I'd mentioned previously, can also increase your risk of a sudden cardiac arrest. So certainly important to make sure you're having regular testing. And again, a plug for the importance of genetic testing to help figure out what the natural history of this cardiomyopathy might be. LV non-compaction is relatively rare compared to the others that I mentioned, but certainly is something that we see and treat. And so I want to mention it because it really seems like the risk of sudden cardiac arrest is related on two different things. So LV non-compaction is where the heart muscle itself has not formed normally, where you get these deep crypts in the muscle instead of it being nice and smooth and uniform and strong. And we know that that increases risk for the function of the heart decreasing, as well as arrhythmias starting to pop up. And when we think about LV non-compaction, the two big things that we look for based on all these different studies are the one, again, what is the genetic testing result? And is the heart function starting to decrease? So we think it's very low risk for any sort of significant arrhythmia unless you have both of these different things. All right, and lastly is restrictive cardiomyopathy. This is a type of cardiomyopathy where the ventricular walls are very stiff. Your heart needs to squeeze to push the blood out, but it also needs to relax to fill up. And when it can't do that, this is the scenario that we get in. And unfortunately, with restrictive cardiomyopathy, this is a very difficult cardiomyopathy to treat, is highly associated with ventricular arrhythmias, potentially needing a transplant. And this is certainly something where we need to be very, very vigilant, looking at how we can protect our patients from cardiac arrest. So I've thrown a lot of numbers at you. I hope you're taking away that, well, maybe it's not as frequent as I thought it might be, even in pediatric cardiomyopathy, but how does that compare to the general population? And I think that's important for us to ask for a little bit of context. So people have looked at this, particularly in the in the studies that have looked back at athletes in particular, but even in the general population, like this slide, which is very busy, I apologize, sort of shows all the different reasons that people in the general population, particularly young people, according to this study, might have a cardiac arrest, okay? So these folks put together 1,866 cases, and they thought that 1,049 of those cases, 56%, were due to some cardiovascular cause of the arrest. And you can see there that almost 40% of those cardiovascular causes never actually got a precise diagnosis. And that's actually pretty common. Still about 40 to 50% of patients who are young with a cardiac arrest, we may never know why that happened, despite our best efforts with the testing that we have available in 2023. And in the individuals where we do confirm an event, you can see there's a whole host of things, okay? Hypertrophic cardiomyopathy is still one of the higher risks in the general population for this, but then you see all kinds of other structural heart disease, infections of the heart, other sort of primary electrical diseases that are not cardiomyopathies that can all cause these kinds of issues too. And so I think there's a number of different things that every time we talk about this, we want people to know that, hey, it's not just the cardiomyopathy patients, it's everybody. And how can we better assess who might be at risk? Well, okay, so what about the ages? What age are we looking at here? Well, it seems based on these two graphs and this study, which admittedly is from 2016, that in the general population of young people, that it looks like there are maybe some sudden cardiac arrest at a very young age. And then as we get into that young adulthood and adolescence, the numbers start to pick up a little bit. And this is another important slide showing the same thing, which I just said, which is that oftentimes we may not know what happened. And more often than not, it's not related to a cardiomyopathy. It's actually related to some sort of structural heart disease or myocarditis or some reason that we haven't yet identified. And while the athletics gets a lot of the attention, as I've already mentioned, out in the news and even in the medical literature, it's important for us to recognize as cardiologists that actually these events can happen anytime, okay? And they can happen at rest with light activity. It can happen when people are maybe just resting on the couch. And so being vigilant, not just to what's happening on the football field, what's happening with activity restrictions, but being vigilant to protect our children 24/7 is really something that's very important to us. So let me pause there and just sort of summarize where we are so far. So we've looked at what a cardiac arrest is, and then tried to march through the different cardiomyopathies. And I hope I've impressed upon you that actually sudden cardiac arrest is relatively rare, even in our young cardiomyopathy patients, and very not uniform between the different cardiomyopathies, even within. And it's very important to talk to your doctor about the symptoms, the testing results, the different things that may increase your risk. And then lastly, while sudden cardiac arrest and athletics are often tied to each other, and there's a lot of discussions probably you maybe have even had with your doctor already, cardiac arrests actually happen outside of physical activity. And so it's not just when people are active, running around on the playground or playing sports that we need to worry about. Okay, so how can we recognize our individuals at risk? We've already looked at some of the predictors within our different types of cardiomyopathy. And all of this is really just trying to make that needle in the haystack as big as possible. I wish in 2023 that we were perfect and we knew everybody who was at a higher risk of sudden cardiac arrest so we could act accordingly. Unfortunately, we're not quite there, although we're getting better and better every year. But still, there's a number of different things I think I've already described to you that will help us figure out what the risk is specific to each child that we see. This is Chad Mao. He is my office mate and the head of our cardiomyopathy program and our transplant program here in Atlanta. And if you remember nothing else from this talk, remember Chad's smiling face and the fact that the most important thing you can do to know what the risk is for your child is to please talk to your doctor about it. Ask them what sort of testing needs to be done to assess the risk of cardiac arrest. Ask your child, hey, what sort of symptoms have you had? Please be honest with the doctor. I know there's probably a tendency we all have to want to minimize symptoms that maybe we've had. Maybe we don't want to admit to ourselves what we're feeling. Maybe we're worried what will happen if we're honest, but that is really one of the most important things. I mentioned to you already that fainting, near fainting are two very important risk factors that we take into account with our cardiomyopathy patients. And so please be honest with that, as well as with palpitations. Sometimes these non-sustained ventricular arrhythmias can feel like skipped beats, or I hear people say all the time that I feel like I have a catch in my chest. These different kind of things, we want people to be honest with us and tell us, hey, I'm having this symptom. Can we look into this a little bit further? So what other testing might be done for your child? Well, it may be as simple as wearing a heart rate monitor. These are just two examples here. Fortunately, in 2023, most places are moving away from the old fanny pack on the hip with all the wires and stickers. Nowadays, it's often just a big sticker that goes on the chest and can monitor your heart for several weeks and look for any abnormal rhythms. Maybe it's a cardiac MRI. For sure, I've mentioned to you multiple risk factors that we can find even with just a simple echocardiogram. And then again, you're going to hear me also continue to hype the November session with the CCF here, as the importance of genetic testing can be very important in helping to assess the sudden cardiac arrest risk. Now, most of these tests are very non-invasive, okay, and can be done fairly routinely on an outpatient basis. Some patients may require what's called a heart catheterization, where we put small tubes inside the heart and measure different pressures or take different pictures of different parts of the heart. But that's not always necessary when we're building a risk profile for sudden cardiac arrest. Regardless, though, these are all tests that are readily available and that you should talk with your cardiologist about. Okay, so let's talk a little bit further. So now we know our risk is relatively rare. We know that there's all these different risk factors and how we're going to find them with routine follow-up and some of these tests that I mentioned. What else can we do? Well, I wish it was as simple as just wrapping our kids in bubble wrap, putting fragile stickers all over them, slapping on a helmet, and being able to watch them 24/7. But as I mentioned to you before, we want our kids with cardiomyopathy to be to be kids and to go live their life, have the best quality of life that they can have. And part of doing that means that we need to make sure we're regularly following up, assessing their risk, and then allowing them to go be kids. And sometimes that may be just making sure they're taking medications. I mentioned to you already that sometimes arrhythmias can be a risk factor, so let's get those treated. Maybe it's the LV ejection fraction or something else about the mechanics of the ventricle that seem to be declining. Maybe there's a medication that we can do. Stay tuned for later in the year as well. This is an exciting time to be in pediatric cardiology because there's new developments, particularly for our cardiomyopathy patients, being developed all the time with several new drugs, even just in the last 5 years. More on that later this year as well. Sometimes your doctor may talk to you about a more long-term heart rate monitor. That's what you see here. This is called a loop recorder. And in some patients, this can be really helpful to say, hey, you know what? A 2-week monitor may just not be long enough. You've had some symptoms that I'm a little concerned about. Let's talk about this. And this may be one option. This is a tiny little heart rate monitor, can last 4 to 5 years, just slides in underneath the skin with a quick procedure and allows you to have real-time 24/7 monitoring all the time. That may be an option to discuss with your doctor, and certainly something we use. This is something called a life vest, which we've also used in some of our patients, particularly in those individuals where they come in and we think they may be at a higher risk for sudden cardiac arrest, but we don't want to do anything more invasive until we can try and help their heart with some different medicines. And sometimes that means, hey, we want to protect you while we try to adjust your medications, try and improve the function of your heart. And maybe we use this life vest, which essentially is like wearing an external AED attached to this pack on the hip. And that's certainly not a long-term solution, but it does provide 24/7 monitoring of the heart rate. And if the unthinkable were to happen, it can actually save a life for sure. And sometimes that's something where if the LV ejection fraction is a little bit low, but we think we can make it better, we'll do something like a life vest for a short amount of time. Those are all important therapies that are out there and things to discuss with your doctor if it comes to that. So this is something very important called implantable cardioverter defibrillators. And if your cardiologist thinks that the risk of sudden cardiac arrest is high enough, they may discuss implanting in what's called an ICD with you, okay? And there are 2 main types that we use in kids that I'll mention here. One being the transvenous type, where we would put the generator, this little silver battery, which has the computer, underneath the skin up here, and then thread wires down into the heart through the veins, as you see in this graphic, plug them into the heart. And that allows us to not only monitor the heart rhythm at all times, you can actually pace the heart if the heart rate is too slow, or if the heart rate's way too fast, sometimes delivering a quick burst of pacing will convert it back to a normal rhythm. And then in extreme cases, such as ventricular fibrillation, these devices can provide a shock to the heart as well and save someone's life. Subcutaneous ICDs are also things that are used. The battery for the subcutaneous ICD is a little bit bigger than it is for transvenous. So we try to use these only in our larger kids. But the advantage of this one is that everything stays outside the chest. So the ICD goes underneath your skin and underneath the muscle, typically underneath the left arm, and then a wire is threaded across the chest and up the middle. And that also allows you to have continuous monitoring of the heart rhythm, and if needed, provide a shock to, again, save someone's life. So why don't we just put these in everybody? You get an ICD, you get it, let's do it for everybody. Well, fortunately, we have these updated guidelines from 2021 from a lot of our colleagues around the globe looking at, who should get one of these? And this is incredibly important. ICDs are not for everybody because many of our patients don't need them. With regular follow-up, with appropriate medications, we don't need to put in an ICD. And certainly an ICD is something that's invasive, something that can put people at risk for arrhythmias or some event during the procedure itself. And then, of course, we're implanting something in the body, so something that could lead to an infection down the road. And certainly one of the big things we worry about is many of our patients then have a lot of anxiety after we put these in. Sitting in class thinking, is this device going to go off? Of course, now you've got a couple scars for these devices, and certainly cosmetically that can cause a lot of anxiety for our patients too. So ICDs are not things that are free, and any decision around an ICD should be shared, okay, between you, your cardiologist, your child. Okay. Our job is to inform of the risks and say, hey, I think we should talk about this. The risk is getting a little high for a cardiac event, but let's make a shared decision about what's right for you. And this is a critical piece of implanting a device, something that we do all the time, but we only want to do it when we need to. Importantly, it can be, our risk stratification is better and better every year, much better now than it was 5 years ago, but it's still not perfect. Even with some of the best risk stratification in hypertrophic cardiomyopathy, for example, authors estimate that you might put in 10 ICDs just to save one life. And so that's a lot of patients getting ICDs who we hope will never use it just to save one person who might. So again, ICDs are wonderful devices. They've come a long way, but it's not something that we take lightly, and we certainly wouldn't do just to say, well, you know what, your risk of activity is a little high right now. Why don't we put in an ICD just so we feel better about you running around on the playground or playing sports? That's certainly something that's not appropriate. So this is a whole topic in and of itself, all right? And I'll just pause here and I'll say there was a wonderful session from earlier this year from the CCF. I encourage anybody with questions about ICDs to go back and listen to this session. You'll hear some overlap from our discussion today. But certainly people with questions about what is an ICD, what are the downsides, when should my child get an ICD, are dealt with in much more detail by these two folks, which is a wonderful talk out of our colleagues at Stanford. So if I can just pause for a second, you've heard me say a lot about, boy, what a great time to be in cardiology. I truly believe that because I think we're only getting smarter and smarter and looking to the future for improvements in our genetic testing, in our medical therapy, even on our devices. They get smaller and smaller, batteries get better. The computer algorithms that read the heart rate are better and better. And so this is a quote from my good friend Steve Tassoni, who actually retired a couple of weeks ago. So this has been on my mind. He liked to say, as he was head of the anesthesia department here in Atlanta, that he would always tell his friends and family, hey, listen, take care of yourself the best you can, take care of your children the best you can, but know that we're here if you need us, and we're getting smarter all the time so that when you need us, we're better than we were yesterday. And that's an important thing. So I hope that you can take a little bit of hope from this talk today, that things are getting better with each year. So how can we, again, prevent sudden cardiac arrest from becoming sudden cardiac death? And this really kind of hits at the meat of how can we as a community, schools, gyms, places of worship, places all over our cities. How can we make sure all our children with cardiomyopathy are protected? Because what we want to be able to do is say, of course, your child can go to school. Of course, we want your child to be able to run around and play on the playground, to do what they want to do. But how can we make sure that they're doing that as safely as possible? And one of the first things to that, to achieving that, is just planning. Okay. We know that failing to plan to keep our patients safe is planning to fail. And so if I can direct you to another podcast, this is a very moving podcast from our friends, the Etheridge family. Colin is a 13-year-old young man you see there with his sister and his parents, who we met several years ago, who was just jogging up some stairs at school to open the door for some of his colleagues. He collapsed and had a cardiac arrest. Fortunately for Colin, his school had a well-practiced CPR plan. He had CPR staff very quickly who were on the scene, and an AED at the school. And for sure, they saved his life. And not only saved his life, but he had a great outcome and is just doing fantastic. And he and his mom have become warriors for taking up the mantle and trying to say, hey, are the places where your kid's hanging out, are the places where your kids are going to school, are they heart safe? And for sure, hearing that from another parent is more than you could ever ask for, and I'm sure is more moving than anything I can tell you today. So I encourage you to go listen to that, because this is something that is critically important for all our students, not just our kids with cardiomyopathy, but certainly our kids with cardiomyopathy who we want to be able to go to school, and hopefully go to school without having to think, oh, I need an ICD just to try and be safe. Well, we know that AEDs in schools save lives. This is very basic. I think in 2023, we all sort of accept that the numbers for survival to hospital discharge after a cardiac arrest at a school is as high as 80%. Compare that to if the first AED on the scene is brought over by EMS, maybe as low as 50%. These are really striking numbers, and thankfully there's a lot of legislation in different states now that are requiring AEDs in all our schools. This is just another highlight here that's a little more updated than what I just showed you, saying that, boy, 60% survival for, these are exercise now, events in 2014 to 2015, but in 2018, now we're getting better and better and better as AEDs are all out there. This is a slide I borrowed from my friend Richard Lampier, who was the first head of Project S.A.V.E. And used to show this all the time, because of course, we all know it's not just enough to have an AED on a campus if nobody knows how to use it. And he's got all kinds of stories when he would go do this in schools and work with schools on emergency action plans through Project S.A.V.E., which is something that we do quite a bit, where they would have the AED locked in someone's office on the weekends. The AED was not accessible by the basketball gym, but maybe you could get it at the football field. A lot of different things to think about. And this is why it really gets to the importance of having not just an AED in our schools, but an emergency response, okay? And that merely having an AED or a bystander with CPR is actually not adequate. What we need is a full response. And this was a statement put out by the School Nurse Association to try and really head this up 6 to 7 years ago, and which is really trying to increase our emergency action plans with the whole goal of maintaining the chain of survival. So the AHA has published this quite a bit, and you can see that these are important things that I want you to talk with your school about, of your child, to say, hey, what would happen if my child had an event? Who here would be able to check my child over if they said they felt like they were going to pass out, or were having a racing heartbeat, or trouble breathing? And maintaining that early call to 911, hands-only CPR if needed, early defibrillation, and then getting people to a higher level of care as quickly as possible. Trying to ideally get CPR started within minutes is ideal. And these are important questions that I hope schools are starting to really take seriously in 2023, as we've seen cardiac arrests become more prevalent. So this is just an example of an emergency action plan, okay? This was developed initially for athletes, but really is something that we use for everybody. When we go into schools as part of Project S.A.V.E. to talk about AEDs and emergency response plans, one of the things that we remind everybody is, hey, we're just as likely to use this emergency response plan on a parent as we are a child. And certainly as part of Project S.A.V.E., we have many, many saves of bus drivers, parents, or older family members, even though we're often there, asked to be there for a child first. So a couple of quick takeaways here. We encourage all our schools, trainers, coaches, everybody, that if you have a non-traumatic collapse, someone is not responding, please assume that it's a cardiac arrest until proven otherwise. And I get asked this all the time by parents who are nervous in my clinic, and they say, hey, how will I know if something happens? And while none of us want to think about this, I always tell them, hey, just assume the worst, call 911. If your child, if your family member, if a school administrator, if somebody's not responding to you, just assume, because there's many distractors. And we get this all the time when we take care of our children who have had sudden cardiac arrest and make it to the hospital where they're evaluated by us. Perhaps there was a little delay in getting a defibrillator because they were having what looked like a seizure, or where their eyes were maybe bouncing around, all these kind of different things that you hear about. And this is why we just say, hey, just assume, call 911 as quickly as possible. Okay. This is just another slide to highlight how challenging this can be and why it's important to ask our schools to think this through. This is a high school in Georgia where the AED was over by the high school and the gym, but you can see the track and the football field were all the way across campus. So one of our roles at Project S.A.V.E. was to go meet with the school administrators and say, hey guys, what if something happened down at the track or at the football stadium? How can we get the AED there? We really only have a few minutes. And how can we make sure that our entire campus is heart safe? Because you really need a number of different components to our school action plans. Who's going to be there that's CPR trained? Needs to be very site or venue specific emergency action plans. Every campus is a little bit different. Every campus has different resources and different access to EMS even. And then let's make sure again that our AED is readily available, batteries are updated, and that it is ready to go. Fortunately, in Georgia, we have state legislation and have for years to make sure that there are AEDs in all schools. This is certainly something to think about if you don't live in Georgia. And there will be legislation coming through very soon, also making sure that we have emergency action plans in place, okay? If you don't live in Georgia, or perhaps your state has not required AEDs yet, you should know that there's federal legislation supported by Damar Hamlin and a number of others in 2023 trying to get federal funding for AEDs in all our communities, okay? Not just the schools that decide they can pay for it out of their pockets, because this is something we really want to get everywhere. This is Project S.A.V.E. This is our website. If you live in Georgia or have any questions about any of this, please feel free to go. Here, we are an organization in our state dedicated to sudden cardiac arrest awareness, trying to have prevention, improve screening for all of our children, not just our athletes, and then education, where we have someone who can go into schools, can help with a drill, can set up an emergency action plan. And we have a way that all the cardiologists in our practice can actually refer our individuals to Project S.A.V.E. And so all our cardiomyopathy patients who come through our clinics, we ask our families, hey, can we reach out to the school and make sure that your child's school is heart safe? If you don't live in Georgia, you should know that Project A.D.A.M. is our national organization. We're an affiliate of Project A.D.A.M. here in Georgia, but they exist all over the country and again have the same mission. And I encourage anybody who's got more questions, hey, what are the resources where I live, to reach out to Project A.D.A.M. and see. And if you don't have a Project A.D.A.M. Resource, please reach out anyway, because we're always trying to expand and find new communities where we can support. So that's all well and good for schools, gyms, and different places, but we know cardiac arrests happen at home. They're not just around activity, as I said before. And I would love to hear from you what barriers you have come across in trying to become CPR and AED certified yourself. Every cardiomyopathy family who comes through our clinics is recommended to have CPR training, but we understand it's time consuming, it's expensive. I encourage anybody who's interested to please go and get CPR trained. It's good for 2 years. It's as cheap as $75 or $80. Most of the course can be done online, and then there's a brief skills check-off appointment. And I encourage family members who are taking care of children with cardiomyopathy to please go and get CPR certified. Which family members should get CPR certified? Well, fortunately, a lot of states have now required that CPR training happen for students, particularly those in high school. But as they've studied this in different parts of the world, they've shown that actually kids, younger siblings of somebody maybe with a cardiomyopathy, are still able to make phone calls. Children as young as 7 to 8 can still know to call 911 and provide important information to that person if they're at home with their sibling, perhaps who's not feeling well. Children as young as 6 can even provide that same information if you've already sat down and gone through them. So we really talk with our families in our cardiomyopathy clinic about, hey, this is something nobody wants to think about. But one of the best things we can do is sort of empower you and everyone in your household who's taking care of your child to be CPR trained and to think through what would we do if something happened. So more resources here on the CCF website. Please go there. You may forget everything that I've said today, but know that there's a lot of great resources here. We recommend AEDs in the homes of a lot of our cardiomyopathy patients. AEDs can be expensive. You can get refurbished AEDs where maybe the battery's been replaced, but it was never used. Still maybe $600 or $700. New AEDs can be $1,000 to $1,500 to $2,500. Not always covered by insurance. However, there are grant programs and other things out there. And talking with your doctor about, hey, should I have an AED at my home? Can you write me a prescription and will my insurance cover it? Are important questions for you to ask yourself. So let me pause there and just say in summary that, listen, thankfully, these events in cardiomyopathy patients are rare. We are getting better and better at identifying children who are at a higher risk, but that risk stratification really requires regular follow-up, honest conversations, regular testing, and if there's a medication we think that can make this risk lower, please take it, and please talk to your doctor about whether that's an option. And then lastly, the secondary prevention piece. If the unthinkable happens, we want our communities to be as safe as possible. We want our families to be empowered to respond in any sort of scenario. And please consider getting CPR and AED trained into your house as well. So let me just pause there. Thank you so much for your time and for having me. Would love to answer any questions, Gina, if there were any in the chat.
Great. Thank you so much. That was very informative and a wonderful talk. We do have a few questions. So we're going to start the session. Just a reminder, please keep your questions general in nature. They're not really, this isn't meant to be providing medical advice, but really just more of a general nature. And any questions that we don't get to, we'll make sure that you get answered regardless. So if we don't answer them in the next few minutes, we will make sure that we get you an answer. But with that, let's start with the first question. Can AED pads for adults also be used in pediatric?
Yeah, so the answer is if that's all you have, absolutely. You know, they make infant pads and small child pads, which are better suited. But for sure, if that's all you have, they definitely can be used even in small children. And I think, again, this is something that's important. If you have an AED at home, how old is your child? Do I need to get a set of pediatric pads? They're much, much cheaper than the AED itself. And certainly when you go and talk to your school about, hey, do you have an AED here? That's important to know which sets of pads. But rest assured, you can use adult pads if you had to on a child. Good question.
Thank you. What impact do frequent PVCs have on sudden cardiac arrest risk?
That's a really great question. And it depends a little bit on what type of cardiomyopathy you've got. It depends on where the PVCs are coming from, and are they coming from more than one location in the heart. So there's a lot of different characteristics, even with frequent PVCs, that your cardiologist should be assessing to say, boy, maybe we can start a medicine to decrease those, or hey, I know these are frequent, but they may not actually increase your sudden cardiac arrest risk. So frequent PVCs are important to know, and certainly something that your cardiologist will follow, but they may or may not increase your risk of cardiac arrest depending on your type of cardiomyopathy. That's a tough one. That's good.
Thank you. Are there particular biomarkers in blood work that would indicate higher risk?
Yeah, that I think that's really important. And I think a lot of the risk stratification for sudden cardiac arrest specifically have not included blood work for the reason that it really is a primary electrical problem. So there are some blood tests that are used more in adults than in pediatrics to look at a sudden cardiac arrest risk. But in kids, particularly sudden cardiac arrest, because it's an electrical problem, we really spend a lot more time in the risk stratification looking at your echo results, cardiac MRI results, sort of rhythm monitoring results, and less about blood tests. There are some blood tests, particularly in patients with dilated cardiomyopathy, that are very important to sort of the overall function of the heart. And we encourage, our patients to make sure that they're regularly checking those as directed by their doctor. But those are primarily looking at the function of the heart, not necessarily helping us risk stratify how things look electrically, if that makes sense.
Mm-hmm. Okay, thank you. Are there particular genetic mutations that are more prone to sudden cardiac arrest?
Yes. And again, this is really important to make sure that if genetic testing has been done, to make sure you're talking with a genetic counselor and your cardiologist to say, hey, here's this result. What does this mean for me? Because there are certain genetic mutations, again, specific to each type of cardiomyopathy, to say, we know this gene mutation has a higher risk of abnormal rhythms. And that's a different gene for arrhythmogenic cardiomyopathy than it would be for hypertrophic cardiomyopathy. Some people actually have multiple genetic mutations. We know that can increase your risk too. So there absolutely are. And again, I'm sorry, I don't know all the specifics, but it's very important to know your genetic testing because yes, and talk to your doctor about it. It can mean that your risk is higher depending on your type of cardiomyopathy.
I'm going to try to squeeze one more in. If a family member has suffered a sudden cardiac arrest, are you more at risk, not necessarily having the other risk factors noted for your type of cardiomyopathy?
Yeah, that is an important one, and one that in cardiomyopathy we think increases the risk. So if you've had a family member who's had a cardiac arrest, now you or your child has cardiomyopathy, that is something important to disclose to your cardiologist, because they will for sure take that into effect. So you need to know what age that family member was, what testing was done for that family member. Did they have a different diagnosis? Sometimes that happens. And then, as I started the talk, we get referrals in our clinic all the time for sudden cardiac arrest. Well, it was really actually a heart attack. That's a different thing. So educating yourself about your family history, like this person who asked the question, is a wonderful question. Please know your family history, know what age they had the event. Did they have an underlying diagnosis? Because that can be very important.
Thank you. We have a couple of leftover questions that we will certainly connect with Dr. Whitehill offline and get you responses. I just wanted to take a minute to remind everyone of a couple of upcoming events as well. And And during the presentation, there were also some links put in the chat for some of these additional resources that Dr. Whitehill mentioned. So please feel welcome to consult those. Our next heart-to-heart chat, these are really small kind of discussion-based groups for CCF families. It's going to be focused on sudden cardiac arrest. So this would be a great follow-up opportunity for anyone here that wants to continue the conversation with other families. And we're actually going to be joined by a special guest, Mike Papali, who is a sudden cardiac arrest survivor. And he is the president of the In a Heartbeat Foundation. And so he will be sharing a little bit of his story and insights. And so just welcome anyone that wants to continue this conversation around sudden cardiac arrest to join us on October 30th. And there's a registration link for that as well that you can sign up to attend. And then thank you for the plug, Dr. Whitehill. Our next webinar is on November 1st. It's on genetic testing and gene therapy. And so we hope you will join us for that session as well. It's sponsored by Tenaya, and we will be circulating that link as well. So all of this is really great information. We are so grateful to you, Dr. Whitehill, for joining us today and sharing your time and expertise. Thank you.
Absolutely my pleasure. Thank you.
Thanks, everyone. Have a great afternoon. Take care. Bye-bye.